In chapter 21, we're going to talk about all of the drugs that are used to treat hypertension. By now, you should all have a good understanding of what hypertension is, but just in case you forgot, I will reiterate that it's a sustained, reproducible increase in blood pressure that is indicated by an increased systolic and diastolic blood pressure. So the number I really want you to pay attention to is a systolic pressure of 140 millimeters of mercury or greater, and a diastolic pressure of 90 millimeters of mercury or greater. That indicates stage 1 hypertension. I'm not going to test you on the different stages. I just want you to really know that number. 140 over 90 is stage 1, and as it gets worse, as the blood pressure increases, more and more pathologies can arise. Hypertension is one of the most common diseases affecting adults living in industrialized nations. In the US, it affects about 30% of the general population who are over 20 years of age. And for some unknown reason, there is a high prevalence of hypertension in African Americans. Almost 45% of African Americans suffer from hypertension at some point in their lifetime. It's known as the silent killer because of the lack of symptomology throughout most of the disease course. So as physical therapists, when you are dealing with hypertensive patients, you're usually dealing with some type of other problem that may be causing the hypertension. So you're dealing with something that's causing this increased blood pressure. Hypertension's really hardly ever the reason somebody would come to PT. They're usually coming to treat something else, and maybe that symptom or that pathology is causing an elevated blood pressure. So those are just some things to keep in mind when you're treating patients with hypertension. So we've discussed the baroreceptor reflex in previous talks. The reflex is really important for monitoring and correcting changes in the blood pressure. And it's really, really fast. The baroreceptor reflex is used for immediate control. It can alter the blood pressure within a matter of seconds. What it does is it alters cardiac output, and it also changes peripheral vascular resistance. Changes in blood pressure through the renal handling of fluid and electrolytes usually takes place over a period of several hours to several days. So the kidneys are going to be implicated in the long-term balance and the long-term control of fluid regulation. Some antihypertensive medications that we're going to talk about are going to exert their effects by acting directly on cardiac output. Others act directly on mediating total peripheral resistance and altering that. And some agents have the capability to decrease both factors. And as we get there, we'll dive more into each of the specific entities of which drugs act on cardiac output and which ones act on total peripheral resistance, and which drugs do both. The humoral factors, such as the catecholamines, as you all may know, catecholamines, epinephrine, and norepinephrine, when they're released from the adrenal gland, they bind to the beta-adrenergic receptors on the heart, therefore mediating an increased response in heart rate. Arginine vasopressin is another humoral factor. Don't worry about that too much. We are going to talk about angiotensin 2, how that is derived from angiotensin 1 and the enzymes that are really important in the catalytic conversion. We'll talk about nitric oxide and the endothelians and the role they play in normal control of blood pressure. And then that equation on the bottom of the slide here, really important for you all to know, that blood pressure equals cardiac output times total peripheral resistance. The underlying pathogenesis of primary hypertension is relatively unknown. Sometimes primary hypertension is also called idiopathic hypertension because, again, we don't know why this is happening. There may be increased sympathetic activity. It may be something to do with our diet, cortisol activation during stressful events, not exercising properly. There could be genetic and epigenetic modulators of hypertension. Obviously, obesity. We talked about the increase in adiposity and how the adipose tissue will basically generate its own blood supply, and that blood has to travel longer distances and has to undergo, there's a lot more stress in the arteries, the arterioles, the veins, the capillaries, everywhere with obesity. Different drugs can elicit episodes of hypertension, as you all wrote in your case 3 analysis. I saw many of you made a reference to many drugs that could cause hypertension, so that was really good. And there are other environmental factors, just exposure to environmental hazards. There's occupational hazards that could lead to increased blood pressure. Again, primary is idiopathic. We don't really know why it happens, but for some reason it does. And it's more common in the African American population for some unknown reason as well. What you all will be experiencing a lot of the time in the PT clinic is patients coming in who experience secondary hypertension. So secondary hypertension is caused by an elevated blood pressure that's attributed to some type of abnormality. Could be chronic kidney disease, could be some issue with the renal system, such as renal artery stenosis. Could be the drugs the patients are taking. Could be the fact that the patient may have a catecholamine-producing tumor, such as a pheochromocytoma, which makes its own epinephrine and norepinephrine. Many different types of endocrine disorders. We've talked about hypothyroidism and hyperthyroidism. Could all lead to alterations in blood pressure. We talked about what else did we talk about? We talked about many things with the endocrine disorders. We talked about pituitary tumors. We talked about hyperpituitarism, increased growth hormonal secretion leading to gigantism, things like that. And also cerebral damage. Cerebral damage, we don't really know the underlying reason of how the damage to the cerebrum causes hypertension in all the cases, but we know that it does. And this chart that is on the right side of the screen, this is a schematic diagram of the possible mechanisms in essential hypertension. So again, I don't need you to memorize any of these particular mechanisms. I just want you to know that we don't understand it and that there's just so much that goes into the regulation of blood pressure. And as physical therapists, this is an aspect of the treatment regimen that you can really make a difference in your patients. When a patient comes in for treatment of some particular disease and the patient has secondary hypertension, if you can do some type of physical therapy modulation or work with the medical practitioner or whatever personnel you're working with in order to correct the underlying pathology, most of the time the hypertension and the elevated blood pressure and the symptomology that goes along with it will resolve if you treat the underlying pathology. As you can see from the chart on the right side of the screen, there are many different types of drugs that are used to treat hypertension. So let's start by talking about the diuretics. The diuretics are used to increase the formation and the excretion of urine. So their use as an antihypertensive agent is because of their ability to increase the renal excretion of both water and sodium. And by increasing the renal excretion of both water and sodium, this in turn leads to a decrease in the volume of fluid within the vascular system. The thiazide diuretics are going to be the drug of choice, followed by the calcium channel blockers, followed by the ACE inhibitors that are going to be used to treat hypertension. So the thiazide diuretics, they are going to work on the early portion of the distal tubule and inhibit sodium reabsorption. By inhibiting sodium reabsorption, more sodium is retained within the nephron. And as more sodium gets retained within the nephron, this creates an osmotic force that also retains more water in the nephron. So you're getting a dual action of both retention of sodium and the retention of water within the nephron. And because more sodium and water have to pass through the nephron, there will be more that is going to be excreted. The loop diuretics, they work in the ascending loop of Henle, and what they do there is they inhibit the reabsorption of sodium and chloride from the nephron. So by preventing the reabsorption of water and these particular electrolytes, more of the water and the electrolytes are going to pass through the nephron itself. And then as you all may know, the electrolytes are passed and exchanged throughout the nephron, but a lot of the sodium and potassium exchange occurs, well, the majority of the sodium and potassium exchange occurs in the distal tubule, where sodium is reabsorbed and potassium is secreted. So again, with these drugs such as the loop diuretics, sodium is going to remain in the tubule where it's going to be excreted. And one thing you need to note with the particular electrolyte sparing drugs, such as the potassium sparing drugs, the whole purpose of potassium sparing drugs is to prevent the secretion of potassium into the distal tubule, but these are not the gold standard choice. These are only used if the patient's susceptible to developing hypokalemia. So again, many different types of antihypertensive drugs. We talked in depth about the diuretics, the sympatholytics. They, as the name implies, it's lysing or inhibiting the sympathetic system. So this is going to have the opposite effect on the fight or flight response. So if I give some type of sympatholytic, this is going to lead to a decrease in the sympathetic influence on the heart and or the peripheral vascular tissue. We're going to talk more about ACE inhibitors and angiotensin II receptor blockers in the upcoming slides, and we'll also dive into the calcium channel blockers in the upcoming slides. So there are, as you may know, many adverse effects that come into play when taking these thiazide diuretics. The thiazide diuretics that I want you to know from this slide, benzoflumetazide, hydrochlorothiazide, and hydroflumetazide. Those are the big ones that I want you to know. Oh, also trichlormetazide. So any of the ones that end in thiazide, those are the really important ones I want you to know as thiazide diuretics. Those are going to be the diuretic drug of choice to treat hypertension. The loop diuretics I want you to know, I definitely want you to know furosemide, because you're going to hear that called Lasix in the clinic all the time. And then I also want you to know torsemide. You also hear that called Demodex in the clinic. As far as the potassium-sparing diuretics go, definitely know amiloride and spironolactone, really important. So again, the adverse effects include fluid depletion and electrolyte balance. So if we're having a patient that goes into hypokalemia due to a treatment of chlorothiazide, which is just a thiazide diuretic, the patient may be put on amiloride so that the patient doesn't suffer the electrolyte imbalances. As we go down the list with the adverse effects, the diuretics decrease extracellular fluid volume and produce sodium and potassium depletion, which I mentioned earlier. They also decrease blood volume and increase cardiac workload, so they could have a hypertensive effect, which is the opposite of what we want for these particular diuretics to do. They may result in impaired glucose and lipid metabolism, and impaired glucose metabolism may be problematic in patients with concomitant metabolic disorders such as metabolic syndrome. Patients may have hypertension combined with insulin resistance and hyperlipidemia, so diuretics should be cautiously used in patients who are prone to different types of metabolic disorders. And then another side effect that you see in many different drug profiles is orthostatic hypotension. So this may occur because of the relative fluid depletion produced by the drugs. You may also notice changes in mood in your patients, and confusion has been reported in some patients who have been on diuretics to treat hypertension for an extended period of time. So the drugs that interfere with the sympathetic discharge, also known as the sympatholytic agents, they should be, they are very valuable as antihypertensive agents. They can be classified according to where and how they interrupt the sympathetic activity. So the beta blockers, you all know these by now, the OLALs. I could pick any of the OLALs and put them on the exam, so make sure that you review this particular list and make sure that you know all of the drugs that end in OLAL. How these drugs work in a hypertensive patient, the beta blockers are going to lower the blood pressure by slowing down the heart and reducing cardiac output. They also have the capability to produce a general decrease in sympathetic tone. And given the fact that total peripheral resistance often increases in essential hypertension, blocking the vascular adrenergic receptors should be an effective course of action. Now let's move into the alpha blockers. The alpha blockers, I definitely want you to know doxazosin, prazosin, phenoxybenzamine, and terazosin. Definitely know all of those drugs there. Also phenoxybenzamine. Sorry if I said phenoxybenzamine twice there. Those are, I want you to know, all four of the alpha blockers. And how they work is they block the alpha-1 adrenergic receptor on the vascular smooth muscle, and they promote a decrease in peripheral vascular resistance. I definitely want you to know the mechanism of action. So the alpha blockers, they have the capability to act directly on the tissues that ultimately mediate the increased blood pressure. And the alpha-1 blockers can be also used as an off-label prescription to treat the symptoms of BPH because they decrease the sympathetic mediated contraction of smooth muscle that's located in the prostate gland. And the reduction of muscle tone decreases the constriction of the ureter and therefore leads to improved urinary flow. As far as the presynaptic adrenergic inhibitors go, the only one I want you to know is reserpine. And I do want you to know the mechanism of action of reserpine. So what it does is it inhibits the release of norepinephrine from the presynaptic terminals of the peripheral adrenergic neurons. So the depletion of norepinephrine from the presynaptic terminal decreases the sympathetic mediated excitation of the heart and the peripheral vasculature. And what this does is leads to a decrease in overall blood pressure. So reserpine is the only drug in this particular category that's still commonly used in the US for the treatment of hypertension. And the adverse effects of using reserpine include lowering the heart rate too much, and we result in a condition known as bradycardia, which you all should be very familiar with. And it can actually induce arrhythmias as well, so be careful of that. So the centrally acting agents, clonidine, guanabens, and guanfacine, all work by inhibiting the sympathetic discharge from the brainstem. And these are all agonists for the alpha-2 adrenergic receptor, and they also work on this other receptor known as the imidazoline type I1 receptors. Just focus on the alpha-2 adrenergic receptor for the purpose of this class. So what these drugs do is when they stimulate both of these receptors or one of these receptors, this causes a decrease in sympathetic discharge to the heart and the vasculature. The drugs listed here, clonidine, guanzabens, and guanfacine, work directly on the alpha-2 receptors as alpha-2 receptor agonists. So again, when these receptors are stimulated, this results in a decreased sympathetic outflow, a decreased cardiovascular stimulation, and in turn an overall decrease in blood pressure. With the centrally acting agents, we get a lot of the anticholinergic side effects, well, similar to the anticholinergic side effects that we've seen, the dry eyes, the dry mouth, the dizziness, and just the general sedation. Now let's shift gears and talk about the ganglionic blockers. So the two I want you to know are trimethophan and mecamylamine. Trimethophan works by decreasing blood pressure in emergencies such as acute aortic dissection or autonomic crisis in people with spinal cord injuries. And both of these drugs work by blocking synaptic transmission at the autonomic ganglia. By blocking the synaptic transmission, they reduce blood pressure by decreasing the systemic sympathetic activity. Mecamylamine is used in many different central nervous system disorders. It's used to treat addiction, it's used in Tourette syndrome, schizophrenia, and many other types of cognitive and mood disorders. They are both used sparingly because of their action on both the sympathetic and the parasympathetic pathways. These agents are essentially nicotinic cholinergic antagonists. So what they're going to do is they're going to block transmission at the junction between the presynaptic and the postsynaptic neurons in both the sympathetic and the parasympathetic pathways. So this could cause a lot of different systemic effects. That's why ganglionic blockers are not the go-to choice, because they have dual action on both the sympathetic and the parasympathetic pathways. So they've been replaced by the vasodilators, and the vasodilators, which we're going to talk about in an upcoming talk, include nitroprusside, the calcium channel blockers, nitric oxide that we take, and the nitroglycerin that's taken sublingually, but we'll cover that in a later talk. The adverse effects of the ganglionic blockers include gastrointestinal issues, urinary retention, visual disturbances, and orthostatic hypotension. The vasodilators, hydralazine and minoxidil, these will be used to treat hypertension in some cases, but they're usually not the first line of treatment. They're usually added to the drug regimen if the patient's not getting the desired effect he or she wants from the other medications. So this is usually used in tangent with the beta blockers and the diuretics in order to produce an effective effect. Although other drugs such as alpha blockers may ultimately produce vasodilation by interrupting the adrenergic supply to the vasculature, the vasodilators are going to work directly on the vascular smooth muscle cells. So phenyldopaum and nitroprusside are given in hypertensive emergencies. Sometimes inhaled nitric oxide is given to treat pulmonary hypertension in neonatal respiratory distress syndrome. And the vasodilators also have the capability to inhibit the contraction of smooth muscle by increasing the intracellular production of second messengers such as cGMP. So the increased amounts of cGMP presence will inhibit the function of the contractile processes in the vascular smooth muscle cells. And by inhibiting the contractile processes, what this will do is this will lead to systemic vasodilation. One of the main side effects of the vasodilators is reflex tachycardia. This is really important. This is a really important side effect for you all to know. Reflex tachycardia occurs because the baroreceptor reflex attempts to compensate for the fall in the vascular resistance that these particular drugs produce. So going back to the top of the slide, minoxidil, you may have heard that before. That's also known as Rogaine. So one of the main side effects of minoxidil Well, it may not be a side effect in all cases. Maybe some people will use minoxidil for the increase in hair growth, but people who are using minoxidil as a vasodilator to treat hypertension may note increased hair growth on the face, hair growth on the ears, the forehead, and any other body surface that contains hair follicles. This mechanism here is really important, and I guarantee you several test questions are going to come from this slide. So let's talk about the renin-angiotensin system inhibitors. The renin-angiotensin aldosterone system, or RAA, is activated when blood pressure falls in a patient. And when blood pressure falls, renin is going to be released. Renin is released from the kidneys into the systemic circulation, and when renin comes into contact with angiotensinogen in the systemic circulation, it then gets transformed into angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme, or ACE. So that makes sense. 1 is being converted by 2 by a converting enzyme. So again, angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. And this particular enzyme is located in the vasculature of many different tissues, but there is a high prevalence of ACE in the lungs in particular. So the conversion to angiotensin 2 elicits a potent vasoconstriction within the body. Angiotensin 2 activation is also going to increase aldosterone secretion from the adrenal cortex, and aldosterone increases sodium reabsorption from the kidneys. And how that does that is aldosterone actually creates osmotic forces in the kidneys that encourage water reabsorption, thus helping to maintain the plasma volume. Angiotensin 2 is also a powerful stimulant of vascular tissue growth, and sustained production results in thickening and hypertrophy of the vascular wall. The thickened vascular wall causes a decrease in the lumen of the vessel, thereby causing additional resistance to blood flow, and can actually lead to an increase in hypertension. So that's why these ACE inhibitors and that's why the activation of the renin-angiotensin aldosterone system can be detrimental to people with high blood pressure. So in order to deactivate this system, we give the ACE inhibitors, which work at blocking ACE. So again, the ACE inhibitors are going to work to stop the production of angiotensin 2. And there are specific angiotensin 2 receptor blockers. I don't need you to know those particular drugs, but what I do want you to know about the angiotensin 2 receptor blockers is that they prevent angiotensin 2 from stimulating the rest of the cardiovascular tissues. So calcium channel blockers can also be used to treat hypertension. Calcium appears to play a role in activating the contractile element in smooth muscle in the same way that calcium initiates the actin-myosin interaction in skeletal muscle cells. So the dihydropyridine agents such as nifedipine and amlodipine are really important calcium channel blockers, and I definitely want you to know that fact. So again, they selectively block calcium entry into the vascular smooth muscle cells, and this leads to an inhibition of the contractile processes, which lead to vasodilation and decreased vascular resistance, therefore lowering blood pressure. Certain calcium channel blockers can increase the risk of myocardial infarction and cancer as well. The reason that they increase the risk of cancer is because these drugs interfere with the normal role that calcium may play in regulating cell growth and turnover. Another side effect of calcium channel blockers that you need to be watching out for as physical therapists, if there is excessive vasodilation due to the calcium channel blockers, this may be very evident in the patient's feet and ankles in terms of swelling. So That's one thing to watch out for. And another thing to watch out for is orthostatic hypotension because of the relative change in blood pressure that the calcium channel blockers elicit. So nothing particular on this slide that I want you to know. I just want you to look at the different pathologies that are listed here: left ventricular dysfunction, post-MI, coronary artery disease, and I want you to look at the pharmacology. This is a standardized list. Not all patients are going to follow this particular list, but what you can see with all of these antihypertensive drugs is that depending on what the pathology is, they are used in different cocktails. So for left ventricular dysfunction, the physician will combine some type of diuretic with an ACE inhibitor, and then if they're not getting the desired response, they'll add a beta blocker. In diabetes, to treat hypertension, the patient will sometimes be started on an ACE inhibitor or an angiotensin receptor 2 blocker. If that doesn't work, then the physician may add a diuretic or a beta blocker. Each treatment regimen is very unique to the particular patient, and not all patients are going to respond the same from the same type of drug administration. So just keep that in mind. And again, nothing particular on the test coming from this slide. I just want you to see the wide variety of usage of these particular drugs and some of the pathologies and the combinations that they're used in to treat these particular pathologies. So this is question 5 of 8 for your interactive learning assignment. Please complete this question and compile all of your questions and rationale into a Word document, and please do not forget to cite your work. When you're citing your work, if you're getting your work from the Saccone book, you can simply cite Saccone in your bibliography. You do not need to list particular page numbers. And this is question 6 of 8 for your interactive learning assignment. I'm not going to go through this slide, but I do want you all to read through here because this is really important for physical therapists who come into contact with patients who may be suffering from hypertension. And this case study here on this slide, this is just for your reference. This is not due. However, I would suggest doing this case study because you may see very similar test questions derived from this case study. So I highly suggest going through this and attempting to answer the 2 questions at the end of the case.